Top Med Talk.
Hello and welcome to Top Med Talk. I'm Kate Leslie and I'm here with my co-host Mike Grocott at the combined meeting of the International Anesthesia Research Society and the Society of Critical Care Anesthesiologists in Honolulu in Hawaii. It's been a great meeting. It's very academic, and one of the best parts about it is the really vibrant poster sessions. And I believe that there are over 1,000 posters here in good old-fashioned paper and cloth format rather than screens. So when you go into the poster hall, Mike, there's hundreds of people talking about cutting-edge research.
It's an extraordinary testament to the vibrancy of anesthesia research, where in the US in particular, because it's the International Anesthesia Research Society, but it's a predominantly US meeting, but with a significant international presence. Amazing set of contributions to have more than 1,000 posters.
It really is, and everything from high school students to professors and chairs. It's fantastic. So on that note, we've got a fantastic couple of guests here, international and US based, to tell us about one of the exciting breaking research projects that were presented at the meeting. So Anika and Matthias, can you introduce yourselves?
I'm Anika Bald. I'm a medical student from Germany and from Berlin at Charité. And I worked as a research associate during the last year at Montefiore Medical Center, New York. And I'm happy to be here and to present what study we did with the help of my mentor, Dr. Eikermann.
Thank you, Anika. So I'm Matthias Eikermann. I'm German, as you can tell from my accent. Came about 18 years ago to Boston to serve as a clinician scientist at Harvard, initially at MGH and then at Matthias Deaconess Medical Center. Based on what I learned there, I was elected to serve as a chairperson at Montefiore Einstein in New York City, which is in the Bronx, in Manhattan, and also in Westchester Medical County, in Westchester County. So I was asked when I took the job to build a department that demonstrates increasing national visibility in research. So my boss, Dr. Filosoa, values research and reputation, and that's what we are now doing. We have a program where we invite international medical students, and Anika is an excellent medical student who just finished her research fellowship.
And for those who are not from the US, so yours is one of really the big three academic centers in New York, is that right?
Yeah, thank you. There's Columbia and Cornell and Montefiore Einstein. And yeah, we are excited to do more and more clinical research.
Fantastic. So that brings us around to your fantastic presentation, Anika. Can you tell us how you did it, what the results are, and then we'll ask Matthias to put a bit of context around that for our listeners at home.
We conducted a retrospective cohort study, including around 32,000 surgical add-on cases conducted by female and male surgeons. We analyzed the association of surgeon gender on the add-on duration, which we define as the time elapsed from case booking till anesthesia start.
So what's an add-on case?
So an add-on case describes cases who were added to the finalized OR or operating schedule at the end of the day. So if you imagine the schedule is done and then you get a new patient admitted to the hospital and they need a surgery, you put them on the operating schedule.
And before we get into the detail, I'm fascinated. This is operational research.
Yes.
Which I'm really impressed by. That it's interesting. You're not yet knee-deep in operations. You're still a medical student, but you've developed a particular fascination for this area. Why was that?
I think it's like a fascinating field because you can help patients really immediately and you can give all your energy into that. And I just like that you don't focus onto one specific topic and then you have like a broad range of different types of medicine, what you can see and learn and can get together.
But specifically the operations bit of it, because there's lots of people do research around different anesthetic drugs or different types of perioperative care, but you're looking at the process of how we manage the theatres as opposed to, say, the physiology or the pharmacology. And I'm just fascinated that has interested you.
I think it's a really important aspect because depending on how everything is organized that can have an impact on the outcomes of the patients. And there were also a lot of studies who investigated such things and could see that this really makes a difference. So I think it's worth to have a look into that.
So where did you get the data? Was it just data from the Montefiore Center, and over what time period?
So the cases we included into the study were collected from 2 different centers, one from the BIDMC in Boston and one from our center at Montefiore Medical Center. And they were between 2014 and 2021.
So in the data set, how did you determine the gender identity of the surgeons?
As we speak about gender and not about sex, this is the self-identified gender given by the surgeon by himself.
That's collected in the hospital system and integrated with the patient data?
Yes, correctly.
And then what sort of analyses did you do to determine the relationship between being a woman or a man and how long it took the add-on case to get done?
So we conducted a mixed effect negative binomial regression analysis,
Wow.
adjusting for a priori defined confounders, which included patient demographics, patient gender, for example, surgical service, case acuity. So it was a really comprehensive confounder model.
And what were the results? All our listeners at home want to know if women surgeons and men surgeons get their cases done quicker.
So the results are pretty fascinating. So we have seen that there was a significant association, a significant shorter add-on duration for patients who were treated by female surgeons compared to patients who were treated by male surgeons by around 18 minutes, which makes an incredible difference. And when we had a look into case acuity, so how cases were classified, how fast they should be in the OR, we could see that urgent cases who should be in the OR within 6 hours had a significantly shorter duration for patients treated by female surgeon by around 28 minutes. And the emergent cases who should be in the OR within 2 hours had an even more magnified effect by having a reduced time of 31 minutes.
Wow.
So just to be clear, so the female surgeons are getting these urgent and emergent cases to theatre faster than their male colleagues. And I think when you showed us the poster earlier, that's not true in the elective context. So it's specific to the emergency context. Now, this is really tricky ground. We need to be careful what we say, but I mean, in terms of mechanism, so yeah, as in why and how do you think they're achieving that?
So as we have this urgent and emergent cases where we see that the females have a significantly shorter add-on duration, we see that, and we don't see it for the non-elective, we think that the female surgeons put all the energy they have focusing on the patients who need immediately treatment, and that they also get not only just put the case into the booking system, but they also actively go to the nurses and people who physically get the patients into the OR and get them all together and say, hey, okay, we have to do that right now.
And Matthias, I think anecdotally this rings true for you?
Yeah, maybe before I talk about my perceptions that were maybe sort of initiating that study. So what we also observed is that women were more willing to accept that their cases are done during late evening hours and even nighttime. So I think that is another indication of the high energy that women, maybe a little bit more than men, invest to treat the sickest patients who need the help, even at the expense of their own sacrifices of their private life at some point. So that is a data point that we can report, and that basically gives some face value to those suggestions.
There were baseline differences in the demographics of the surgeons, though, weren't there? The women surgeons are younger than the men surgeons.
Yes, that is true. They were younger and they had less experience. So they had the number of cases in the institution that were done before that index case that was analyzed in that study. was different. So women had less experience. We took that into account also as a confounder. And so maybe you could say it's a possible mechanism that could explain why they're a little bit more enthusiastic, because they might have not been as burned out. But, it doesn't really affect our conclusion because we controlled for the experience level of the surgeons.
So this is obviously team surgery. Did you also look at team anesthesia and the interaction between the two? So, for example, if you had a female anesthesiologist and a female surgeon, were they faster than the equivalent male partnership, or do you not know?
That is an excellent question. We haven't done it yet. We have Dr. Kate Leslie, who runs this show, has published an article on a similar topic where investigators looked at the gender of the anesthesiologists and the outcome of the patients, and it came from the same institution from Boston that I had also the pleasure of serving at. So similar findings, but what you are referring to, the concordance between the gender of the surgeon and the gender of the anesthesiologist, that we haven't yet examined, but it is an interesting idea.
And a sort of related but slightly more provocative question. Have you been to surgical conferences and told them about this?
Well, I can say that the paper is currently under revision at Annals of Surgery. It's a surgical journal. The editors and the reviewers had some questions, but they lack the findings. So I think there is a lot of surgical literature on gender differences and outcomes. Annals of Surgery published a meta-analysis indicating that there is a gender difference. I think the surgeons are getting more and more open to those important questions.
There's other literature, Anika, that suggests that women are required to try harder and to achieve more in order to be perceived in the same way as men. From your research, it's hard to get information like that out of a database. But what are your thoughts about that and whether it drives these data or in fact, your career and mine? I certainly have felt that way from time to time in my career.
I actually thought about that too, and I saw this information and research, and I totally agree, and I experienced by myself the same, that as a woman you run against walls and you have to try harder and more persistently to get through these walls. And I think for most women it's hard, but at the same time seeing other women like crushing these walls, just saying it in that way, is motivating. So I always try to push the line to do as much possible. And I think a lot of women do that too, and that I actually think it influenced that.
So the point of your research and all this research is not to say, women, rah, rah, aren't we great? It's to identify the characteristics of human people that result in better outcomes and then try and broaden that across all providers. So as the chair of a large health system, how are you going to use these data to stimulate further research or to change practice?
Well, this is an excellent question. So I think the chair, it is important to make sure that we have inclusive and diverse workforce. And when I talk about inclusion and diversity, I mean race, ethnicity, gender. And this will still be the case in the future. As you know, in the United States, there has been a new administration with a new focus, and we might use a different language for this, but those are important markers of the quality of care that we provide, and we will focus on it. So that is a big focus of what we do to create the best workforce. And two of our surgeons from Montefiore co-authors, they were quite happy to see the results, and they felt, the appreciation also that we could give them by showing how good they were. And I can say, initially as an anesthesiologist who worked at floor manager also at different hospitals, I believe to see that women sometimes are better communicators if it really matters, that they go and talk to the floor manager, talk to the charge nurses and get that patient on the schedule faster, whereas maybe some more experienced professors would send their resident to book the case and go back to the office and write a paper, which is not a bad thing to do, but because we want to be academically active. But I would like to see what we can learn from the women, why they are more successful. I think this could be one mechanistic piece. I'm sure there's more that we can learn.
Take whatever it is that gives that characteristic that enables a faster time and see if the whole team could achieve the same thing, I guess.
Yes.
And now, I guess the really important bit that I think we've neglected to mention so far, what happened to outcomes but between the two different surgical groups?
When we look into the literature, we see that the outcomes are better for patients treated by female surgeons compared to patients treated by male surgeons, including postoperative mortality, which is significantly lower for patients treated by female surgeons, which also a recent meta-analysis has shown, which was published in Annals of Surgery. So our study gives like one specific possible explanation for that.
And you showed an outcome difference as well, didn't you, in terms of length of stay?
Yes, so we also saw that the postoperative hospital length of stay was significantly reduced for patients treated by female surgeons.
Which really raises the stakes in terms of how can we get everybody to perform in a similar way. Huh?
Yes, correct.
Great work.
So what's next for you, Anika?
So actually, I'm sadly leaving back to Germany, so my stay is over, but I will continue working with the lab because I take a lot out of this year. I learned a lot regarding a lot of different things, including data analysis, how to become more self-confident. So I grew personally and professionally a lot, and yeah, that's the next step, going back to Germany, finishing my med school.
So going back to Berlin would not seem to be a terrible fate by lots of our listeners. It's such an interesting and fascinating city. So we wish you all the best with your medical career, and we hope that you pursue whatever you want, but keep up with doing research.
Yes, I do. Thank you so much.
So thank you to you both.
Thank you.
And thank you, Mike.
Yeah, no, thank you both. And I mean, great, Anika, for, taking the opportunity to, it's a big step to step out, go across the Atlantic for a year, but also Matthias for having a program that enables that, because it's not a common opportunity, and I think probably quite an important one.
Terrific. We'd like to thank our sponsors, BD and also GE Healthcare. Without their help, we wouldn't be able to bring Top Med Talk live and open access to the world as we're able to do. So we're very grateful for their support.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.